Hi, Dr. Mike Gibson, Dr. Naidu here, talking about interventional cardiology and heart failure. We face an epidemic of the walking wounded with heart failure, even though they survived an MI or some other process, they have impaired LV function, and it's a big cost driver in the United States, probably one of our biggest healthcare cost drivers. What can we do to, treat these patients or help in the diagnosis as interventional cardiologists?
Right, I agree. So this is the birth of interventional heart failure. So,
yeah.
The concept here is that there are a lot of patients with heart failure. And by and large, we as interventional cardiologists have really felt we're proceduralists. We see mitral regurgitation, we want to fix mitral regurgitation. We see aortic stenosis, want to fix that. We see a blockage, we want to fix that. The reality, though, is that I think everything that we're doing that is meaningful is really surrounding this topic of heart failure. And you're right, it's an epidemic, and we need to, as a community, rally behind this to try to mitigate the incidence and prevalence of heart failure. So as interventional cardiologists, I think we have to really think differently. We have to think about how we can look at the substrate of the patient, look at their clinical symptoms, and how can we improve those clinical symptoms. Medicare and others are looking at that. They want us to reduce readmissions. They want us to improve quality of life. Maybe it's not so much about survival, or it is, but not as much as how the patient's feeling.
So rather than adding years to someone's life, adding life to those years they have left.
Well, exactly. So what does that mean for us? That means that we need to re-educate ourselves on invasive hemodynamics. And I don't just mean doing a quick right heart cath and finding the wedge. I mean understanding the differences between pericardial disease, mitral disease, aortic disease, muscular disease, diastolic function, systolic dysfunction, pulmonary contribution to reduced cardiac output, and really understanding which of those are the top 3 aspects that can be changed. And then talking to our heart failure colleagues and also convincing them that there's more than the medications and the end game, which is VADs and transplantation. Ultimately, if we can take these patients and utilize therapies that can push them back towards subclinical disease, we will give them better life, longer life, more meaningful life, and likely cost savings.
So what strides are we making? What kind of early success stories have we had with this?
Right. So there's strides in the community. So for example, I think there's now more awareness that there's more that we can do. So I see now more young people or older people, everybody wants to learn more about this. And what I'd like to do is see in this committee a way to maybe create pilot programs at different hospitals where they can put together heart failure boards and now infuse into that an interventional cardiologist. But not just any interventional cardiologist, the person with training in advanced hemodynamics and an understanding of physiology and an understanding of all the treatment modalities, whether or not he or she does it themselves, that can be utilized, and an understanding of when and why and the sequence of different therapies, including medical therapy. On the national front, we're going to push this in terms of education because I think our field is changing and I think we have to change with the times.
Exactly. Well, we're plumbers. We saved their life through better plumbing, but now we have to make them feel better now that we've given them a second chance.
So I think you're absolutely right. After we fix them, we fix the blockage, but there may be significant disease, there may be significant other disease, there may be significant valvular disease, and they may have continued remodeling that is overwhelming the medical treatments that we do. We need to start predicting which patients are going to go that route and being much more proactive earlier in the game.
Right, I agree. Dr. Naidu, thank you for joining us. Thanks to all of you for joining us here live from San Diego here at SCAI 2015.
Thank you.